also take one or two questions if time permits after the talk. So Dr. Usha is a consultant endocrinologist at Apollo Hospital, Chennai, and she's going to update us on diabetes in pregnancy, the management, the update on management. Over to you, Dr. Usha. Thank you.
Many thanks for your extremely kind introduction, Shruti. Now, I have half an hour for this talk. I'm going to try and wind it up a little quicker. I know because we're running a little late to start with. So, diabetes in pregnancy, what do we need to know about update on management? Now, the entire state of pregnancy is a goal towards uninterrupted nutrient supply to the fetus. But this needs to be a balanced supply in early pregnancy to develop the anabolic stores to meet the metabolic demands of late pregnancy, and in late pregnancy to fuel the growth of the fetus. This means that the maternal blood glucose supply needs to be in a very tight control because under or over will affect fetal parameters. Now, mom eats, the plasma glucose goes up, and this triggers a whole set of hormonal adaptations. The insulin goes up, the glucagon goes up to mobilize hepatic glycogen, somatomedins and adrenal catecholamines go up. All this ensures that both mom and fetus have an adequate glucose supply. As you go from first to second to third trimester, the increasing estrogens and progesterones and chorionic somatomammotrapins, basically what these do is they increase tissue insulin resistance so that the insulin levels are 50% higher than in the non-pregnant state. This is significant because insulin also acts as a growth factor to the fetus. Now, this also means though that interprandial hypoglycemia is quite common as pregnancy progresses and the fetal glucose demands increase. So it becomes quite a tricky balance of ensuring adequate but not too much and not too little. So the physiology, we know that insulin resistance increases due to all these placental hormones. We know that maternal hepatic glucose production increases by 15 to 30% to meet fetal demand in late pregnancy. At the same time, any pre-existing pancreatic beta cell dysfunction is exaggerated because of genetics in our case and insulin resistance. How does this cascade? You have inadequate maternal pancreatic insulin response. This leads to maternal hyperglycemia, leading to fetal hyperglycemia because the glucose crosses the placenta. Maternal insulin doesn't cross the placenta, but the fetal hyperglycemia leads to fetal hyperinsulinemia, recurrent postprandial hyperglycemia, and this triggers accelerated fetal growth. At the same time, fetal hyperinsulinemia leads to excess nutrient storage, and this causes macrosomia in the fetus. Now, the fetal hyperglycemia drives fat metabolism in the fetus. So the excess glucose is laid down as fat, especially in the abdominal area. But at the same time, this excess fat metabolism depletes the fetal oxygen levels, which leads to a surge in adrenal catecholamines in the fetus. What this does is then trigger hypertension, cardiac remodeling, stimulation of erythropoietin and red cell hyperplasia, increased hematocrit, and these are the reasons for the hyperbilirubinemia and neonatal jaundice that we see in the fetus postpartum. All the management that we do in pregnancy is geared towards preventing or minimizing all these complications. Now, this starts in pre-gestational diabetes with preconception care and in women that we think are prone to diabetes. The entire system, as I said, is geared towards optimizing maternal and fetal outcomes. This is important because these outcomes start as early as 3 weeks after ovulation before the woman even realizes she's pregnant. So in pre-gestational diabetes, we must ensure that preconception A1C is as close to normal, less than 6.5 as possible, because caudal regression, spina bifida, so the neural malformations start as early as 3 to 5 weeks, renal and cardiovascular 5 to 6 weeks. So these are very early before most women realize that they're pregnant. So all women of childbearing age, irrespective of the condition, whether they have pre-gestational diabetes or not, should be provided counseling on effective contraception. And for those who wish to prepare for a pregnancy, weight control, nutritional counseling, and those with pre-gestational diabetes change their medications, statins, ACE, ARBs, and most non-insulin anti-hyperglycemic agents should be managed. Ideally, ADA recommends an A1C less than 7 preconception, ACE tightens that to 6.5, as long as it's achievable without hypoglycemia. Once the woman is pregnant and we have a positive pregnancy test, for pre-gestational diabetes, the pathway is slightly different, but I'm going to show you just one slide on diagnosis. If the woman doesn't have diabetes, universal screening in the Indian population at first presentation and subsequently at 24 to 28 weeks, first trimester with at least fasting plasma glucose and the fasting 75-gram OGTT at 24 to 28 weeks. These are the cutoffs, 92, 180, and 153 at fasting 1 hour and 2 hours post-challenge. Remember that those are the cutoffs for diagnosis, but for treatment, the goal is 95, 140, and 120 at preprandial 1 hour and 2 hour postprandial glucoses. But for pre-existing or type 1 or type 2 diabetes, most people propose an even tighter glycemic control of 60 to 100 preprandially and 100 to 130 postprandially. This is because the HAPO study has showed us that any serious perinatal complications are improved with tight glucose control. And remember that most of the outcomes of the HAPO study, except for fetal mortality, neonatal mortality, and ICU admissions, were based on the 1 hour postprandial glucose, not the 2 hour postprandial glucose. So we should be looking at 1 hour as much as possible. During pregnancy, please screen for renal, cardiac, and neuropathy, as well as retinopathy every trimester and 2 to 1 year postpartum. Target your systolic blood pressure to 120, 110 to 130 and diastolic to 65 to 80. This must be routine at every clinical visit, and reiterate your lifestyle modifications and pregnancy weight gain at every visit. Now, patient education starting from preconception going through all stages of conception and pregnancy. Glycemic monitoring and targets in pre-gestational diabetes at the very least 3 times a day if they're on insulin. So type 1 diabetes at the very least pre-meal and 1 hour post-meal and before bed, ideally. And in terms of pros, it allows people to become aware of their carb intake, and this is more applicable to type 1 as well as gestational, and how to minimize these postprandial excursions. You can use glucose monitoring CGMS with pregnancy. If you're doing SMBG, you know that you can miss certain high and low values. A1C gives you an overall picture, but doesn't give you the granularity. And I'll show you some data on CGMS. As I said, HAPO for diagnosis suggests OGTT to be a much better option than either fasting plasma glucose on its own or HbA1c on its own, because of the shifts in A1C with your hemodynamic shifts in and nutritional shifts in type 2 diabetes and pre-gestational diabetes. If you're using CGM, please understand it's an extremely useful tool. It does provide a lot of education and real-time feedback to the women in terms of their carb intake, but it requires a lot of knowledge on behalf of the provider and a lot of patient education to be able to achieve an idealized scenario. So diagnosis, OGTT, monitoring can be either CGM or SMBG. Now, we know that CGM does help the risk, reduce the risk of macrosomia in type 1. These are data from type 1 diabetes. If you look at weeks of gestation, early pregnancy 28 to 32 and 32 to 36 on the left of your screen. And if you look at infants with macrosomia on the right of your screen, you will see that the A1C is better in women with type 1 using CGMS, and that the risk of fetal macrosomia is significantly less in women using CGM. This is the only data we have in terms of use of CGM in pregnancy for type 1 diabetes. Coming on to medical management. The goals, as I said, are to optimize fetal nutrition whilst minimizing complications for mother and fetus. I'm going to talk to you a little bit about nutrition. Please make sure that you have a dietitian who is trained with maternal nutrition in pregnancy with specific emphasis on the cutoffs for weight gain. We know that Dr. Bharat talked about this briefly in yesterday's talk, but it is not a uniform 10 to 12 kilo weight gain for every woman. If you have a woman starting with a BMI less than 22, obviously your calorie requirement is more. If you have a woman starting with a BMI over 30, for example, they need to gain practically no extra weight in pregnancy. So the weight gain limits go from 4.5 to 5 kilos for obese or overweight women to maybe 5 to 9 kilos for women who start with a BMI in the overweight but not obese category, and 10 to 12 kilos for women who start with a normal BMI, perhaps, and you have an allowance for twin pregnancies that is slightly higher than this. Add approximately 4 to 5 kilos per category. Medical nutrition therapy recommends losing low carbohydrate, high fiber sources of nutrition with vegetables as the preferred carbohydrate source. We need to teach them to SMBG post meal and adjust their carb intake to the SMBG. It's best to avoid simple sugars in the form of added sugar or fruit juices or highly processed foods. And the best strategy might be small, frequent meals to spread out the carb content. Because remember, you can't carb restrict too much or you'll end up with a small baby. So you need to have adequate carbohydrates, but perhaps spread out to reduce the load at any one meal. Physical activity is absolutely not contraindicated unless the obstetrician says, for reasons of perhaps a low-lying placenta or bleeding or spotting in pregnancy, except for very specific situations, physical activity is actually recommended. Moderate intensity, not even low intensity, moderate intensity, at least half an hour per day, perhaps more for your women who start out obese or overweight. And remember, targeting physical activity to the postprandial period can also help you achieve good postprandial glycemic control. As I said, healthy weight gain targets are based on recommendations of starting BMI. And if you have a good weight distribution in pregnancy, you avoid fetal-maternal complications. Weight management, women who start pregnancy with a weight that is over 30, BMI over 30, it's an independent risk factor for cesarean delivery, infant birth weight, and cord blood serum C-peptide over the 90th centile. So starting with the correct weight and avoiding excess weight gain in pregnancy is important both for the mom and the fetus. Now, pharmacological therapy. Yes, India is a country where we can't avoid oral anti-diabetics. So I'm going to show you the pros and cons of each. Ideally, recommendations are for insulin, but I'm going to show you for both. If you look at OADs, this is the ADA recommendation. Only metformin and glyburide are considered safe. If you look at metformin, the role still remains controversial, but that's because countries that can afford to do these clinical trials have no investment in looking at metformin. They can afford to prescribe insulin. Part of the concern is because metformin crosses the placenta and fetal concentrations are similar or higher than those of the mother. 2017 compared with insulin, and please note the first three studies I'm showing you are insulin versus metformin, and the final one, the MIGHTY trial, is insulin plus metformin. Insulin versus metformin reduced the risk for neonatal hypoglycemia and pregnancy-induced hypertension, but there was no major difference between preterm delivery, small for gestational age, perinatal mortality, and cesarean deliveries. Again, 2019, metformin exposed children had, and this is post delivery followed up into childhood, they seem to have a higher BMI and evidence of increased adiposity by mid-childhood compared with insulin-exposed children. So although there are no small or large for gestation age babies, in childhood they have a risk for adiposity. This is 2020, a meta-analysis of randomized controlled trials limited to women with gestational, not pre-gestational diabetes. They looked at insulin versus metformin again. It reduced gestational weight gain, birth weight, risk for macrosomia, and risk for LGA infants was similar across both groups. Then the MIGHTY trial, I'm going to take a minute or two to elaborate on this. The maternal outcomes. So what they did in the MIGHTY trial is they actually looked at metformin plus insulin. So this is not versus insulin. Women got the benefit of both metformin and insulin. And if you look at the maternal outcomes, I'm going to show you the highlights. Overall weight gain was significantly less where metformin was used. A1C was much better in women using metformin, and the total insulin dose was much less at each trimester. Prandial and long-acting insulin doses were much less in the MIGHTY trial in mums on metformin plus insulin. In terms of fetal outcomes, Neonatal hypoglycemia was much less. I'm just showing you the highlights. The trial itself is a very beautiful trial. You should have a look at it in detail. And the birth weight was much less in the group that were on both metformin and insulin. And neonatal body fat mass, as you will see, was different, as well as the skin fold thickness. So they seem to carry less fat during pregnancy. We need to wait to see if this cohort of children behave differently into childhood, where only metformin seems to give you childhood adiposity. Now, they also had hyperbilirubinemia, which was slightly more in the metformin plus insulin group. Looking at glyburide, there are a few trials. This one is hot off the press, November 2020, and essentially they say it's an effective treatment for reaching glycemic goals during pregnancy in women with GDM. But the problem is this is only 890 women, and it's difficult because, as I said, the countries where we use these agents, we are not investing in the clinical trials, and the countries that do the clinical trials are not particularly invested in this. So this is a critical appraisal from about a decade ago, but essentially what they said is the clinical experience is way ahead of the science. We don't really have good RCTs and we need to design them. And the questions still remain about neonatal metabolic morbidity and maternal outcomes. We seem to agree that there is good glycemic control. Neonatal and childhood metabolic comorbidity needs to be evaluated, and we need to design those trials. So both metformin and glyburide, there is evidence that is gathering, but the verdict is out there. If you look at insulin, these are the ADA guidelines. Yes, we use glargine routinely in pregnancy, but they've given it a class C category, as also glulisine and inhaled insulin. The rest, including Lispro and Aspart, as well as regular insulins, are all class B. You initiate insulin when the fasting is over 105, 1 hour over 155, or 2 hour over 130. And approximately, if you are not previously experienced with initiating insulin, these are the guidelines. In the first trimester, you could use approximately 0.7 units per kilogram body weight. And by the time you come to the last trimester, it comes up to about 1 unit per kilogram body weight. We know that it increases. But remember that by immediately after delivery, your insulin requirements will decrease by about 50%. So if these are women with type 2 who continue to require insulin, as soon as the placenta is delivered, please reduce the amount of insulin, otherwise they'll end up with hypoglycemia. What kind of insulin is really subjective to the pocket of the user, because as you will see here, NPH and insulin detamere, as well as regular insulin, Aspart and Lispro, have all been given the same kind of class use. And for those who can afford it, certainly your analog insulins minimize the risk of hypoglycemia. But we know that with good clinical experience, you can actually minimize hypoglycemia, whatever the insulin you can use, with the combination of doctor experience and good patient education. However, if the mother does have hypoglycemia in pregnancy, this may be related to increased fetal glucose needs in pregnancy because, as I said, glucose crosses the placenta and the fetus burns glucose. Risk factors in pregnancy are no different from those outside of pregnancy, but remember, again, in pre-gestational type 1 diabetes, the insulin requirements can go down in early pregnancy, precipitating severe hypoglycemia in the early trimesters. And these are also women that are at risk of impaired hypoglycemia awareness. The longer the duration of diabetes, the tighter the control pre-conception, and the higher the daily dosage of insulin, these are women who are at risk. Clinical consequences, unfortunately, the worst can be coma or death, but there is an added risk in terms of maternal seizures or hypoxia, and this can affect fetal well-being. If you want to minimize this, again, the strategies are no different than outside of pregnancy, frequent SMBG testing. This is where CGMS comes into its own, and dose and administer accurately, and please ensure that they have adequate carbohydrate intake. For labor and delivery, ideally managed with women with gestational diabetes may not require anything except monitoring. Women with pre-gestational diabetes or type 2 diagnosed in pregnancy will need sliding scales or ideally intravenous infusion if you have the facility. Monitor every 4 hours post-partum as well to make sure that they're adequately controlled. This is really, this is a specialist area which you get with experience, or it can be protocol driven, and ADA as well as ACE provide enough protocols for this kind of a scenario. Now, the reason that peripartum maternal glucose control is important is because as your maternal glucose goes up, the neonatal hypoglycemia risk increases. The magnitude of neonatal hypoglycemia is inversely related to maternal hyperglycemia at delivery. The higher the mom's sugars, the more likely the baby is going to end up in NICU with hypoglycemia. So please pay special attention in the peripartum period, not just throughout pregnancy. Now, finally, in the last 30 seconds, please remember that our management of pregnancy diabetes does not end with delivery. We know that a large proportion of these women will go on to develop diabetes later in life. And certainly, if they're planning a second pregnancy, there is a much higher risk of gestational diabetes in that delivery. And we should use the inter-pregnancy period for weight loss and optimization of all other risk factors. Shruti, I think I've managed to do that in 20 minutes, saving you some time. And I'm happy to take questions.
Thank you, Dr. Usha. That was, as usual, excellent. I know you have another talk to go to, so we'll take some questions before you leave. No?
Plenty of time, plenty of time.
So do you think we can take the questions at the end of the next session?
Oh, no, not that much plenty of time. Plenty of time.
Oh, okay. Okay. Oh, I thought when you meant plenty of time, I thought you can wait for another half an hour. But so far, there are no questions in the chat box. I just had one question.
Yes.
I've had a patient who was on alpha glucosidase inhibitor, and she did do well during the pregnancy. And AGI is also being studied, especially acarbose, not voglibose.
Yeah.
Do you have any experience? Because it is being used in some centers for GDM and also pre-gestational diabetes. And it seems to be working for some women as well. What is your experience with alpha glucosidase inhibitor?
I'll be honest, Shruti, by the time I see the need for that kind of glucose control, I move to prandial insulin. Because,
okay.
Look, no matter how much we try, especially you and I both practice in Chennai, no matter how much we try, these simple carbohydrates are such a battle to manage in pregnancy, given the combination of insulin resistance and that immediate spike. And we're aiming for the 1 hour control. AGAs are great to get it in control. And we know that you know that graph where it shows the absorption is slower and it's a 2 to 4 hour process with AGIs. We want it at 1 hour. So by the time we're at that stage, struggling with control, I just move to prandial insulins. If people have experience with AGIs, it would be great to hear about it in a future meeting. But for me...
So you have not been using that for your patients?
No.
So it's predominantly metformin plus insulin?
Metformin for basal control, prandial insulin. And this is, I know that both of us have been doing this, and the MIGHTY trial actually supports our practice. And in those with whom I can't get adequate control with metformin alone, then basal insulin, prandial insulin.
But there are some patients who prefer going on insulin, and I leave them on insulin. I don't put them on metformin. I leave it as a discussion, what patients want out of it. I mean, I generally don't start metformin unless they are comfortable, even though there is data out there for metformin, but I generally use it only if the patient wants it. I mean, if they don't understand.
There are two things I do. One, I have an open discussion with the patient. If you're insistent, I would still prefer basal insulin, but if you're insistent, I'm going to go with the metformin. These are the pros and cons. This is the pregnancy risk of a small for gestational age infant. This is the childhood risk of potential obesity. That is number one. Number two, I document clearly in the prescription out of license use and risks explained to the mother and family in black and white on the prescription.
Thank you. And there's a nice question from Dr. Sahu in the chat box. He says, what about the first trimester? We talk about gestational diabetes. What about a pre-gestational diabetes mom getting pregnant? Would you be comfortable in using metformin in the first trimester of pregnancy? Because there's hardly any data for that, right? So would you stop it and then restart it later, or what has been your practice?
So evidence-wise, we know that all these are category B drugs. They are not ever going to be studied in pregnancy. Nobody's going to run a clinical trial in pregnant women.
Right.
B is wide experience. And a lot of the experience we have for metformin in pregnancy actually comes from those women with PCOS who fall pregnant on metformin and have been on metformin for 12 weeks before they realize that they're pregnant because of the irregular nature of their menstrual cycles. A lot of the evidence we have comes from there. However, if you go back to the guidelines, the ADA does not make a difference between first and subsequent trimesters. It just says metformin and glyburide for use in pregnancy. Also, I know in rural India and certainly in Africa, and I know we have some speakers from Africa on the panel here, so they would be more qualified to answer this. Sulfonylureas glyburide is widely used pre-gestationally and throughout pregnancy, including the first trimester. So metformin is my go-to. I don't use sulfonylureas, but I'm quite happy leaving women on metformin in the first trimester.
So not just Africa, even in United States, glyburide is used. We used a lot of glyburide in pregnancy. Metformin glyburide alpha glucosidase inhibitor. We have used that for a lot of patients. That convincing the patients to go on insulin is incredibly difficult. You know, a lot of them would just deny it. In those patients, we have just used it, and we have not come across any major issues in those moms who delivered. But again, it's just not in like rural areas and setup. Even in well-developed countries, sulfonylureas, alpha glucosidase inhibitors, and metformins are still used for pregnancy.
So in the UK, it was metformin or insulin. Coming back, and I've just continued that practice in India. Personally, no, I don't use sulfonylureas, but I've shown you the evidence for and against it.
Right. So there are no other questions in the chat box. Do you think we can close this session?
Absolutely, sure, and I think we've given Dr. Vijay Bhaskar Reddy those extra few minutes he needs. We're closing at 12 as promised, Dr. Vijay.
Yeah, so it's exactly 12 and we're done with the talk and discussion. Thanks, Dr. Usha. Thank you very much. Bye.
Thank you.
So we'll move on to the next speaker. Dr. Harita, over to you.
Yeah, thank you, Dr. Shruti. Good morning, everyone. It's my pleasure to introduce the next speaker for this session, Dr. Veronique Nicolai. She is the head of the Gestational Endocrine Clinic at Chris Hani Bharadwalnath Academic Hospital at the University of Witwatersrand, South Africa. She has several publications to her credit, mainly focusing on thyroid disease in pregnancy and diabetes in pregnancy. Over to you, Dr. Veronique.
Can you please unmute yourself, ma'am? You're on mute. Kindly unmute. Yeah, thank you.
Good morning. Can you hear me? Okay, all right. Good morning, everyone, and thank you so much for hosting me at this International Congress. I look forward to giving you an update via case presentation this morning on the management of thyroid dysfunctions in pregnancy. Can you all see the talk and hear me clearly? Okay, so just to start, there are no disclosures from my side.
Okay. No.
Yeah?
I'm sorry, go ahead. Sorry.
Okay. So, and then obviously there's a various guidelines which have been consulted in terms of the approach to the various cases, which we will run through this morning. As you're all very aware, in the last 3 to 4 decades, there's been substantial expansion of our knowledge in the field of thyroid disorders in pregnancy. The diagnosis of thyroid disease during pregnancy requires an intimate knowledge of the physiological changes that occur within the thyroid.
Ma'am, sorry to interrupt you. Can you share your slides, please?
Can you not see them?
Yeah, your slides are not there. Yeah.
Not visible.
Okay, let me try again. Is that clear?
Yep.
Yes, ma'am. That's perfect. Yeah.
Apologies. So we were just saying that to appreciate the thyroid disorders in pregnancy, one needs to understand the intimate relationship with thyroid physiology changes together with thyroid function changes. And as you're all aware that the thyroid disorders in pregnancy can have an immense impact on pregnancy outcomes for both the mother and child alike. So with that, I'd like to start with our first case. And we have a healthy 30-year-old lady. First pregnancy, she's referred to you to have her thyroid tests evaluated. There's no personal or family history of thyroid disease or any other autoimmune conditions. And she's currently taking a prenatal vitamin containing iodine, but otherwise has been fairly healthy throughout this pregnancy. So she consults you at 28 weeks gestation, so early 3rd trimester, when her obstetrician ordered an oral glucose tolerance test. They then decided to check her thyroid functions together with this because they've heard of the adverse effects thyroid disorders may have on the pregnancy. And these are our results. So this is the early third trimester. So her TSH is 0.72, which would be acceptable for this stage. And we have a free T4 of 0.36 nanograms per deciliter. As you can see, for this stage of pregnancy, we tend to adopt non-pregnancy normal ranges, but this is certainly significantly low. Sorry, I don't seem to be able to move my slide. Let's just try. Okay, so what would we consider at this point? Would you suggest that she's potentially iodine deficient and needs more iodine supplementation? Could this represent a central hypothyroidism from lymphocytic hypophysitis? Could this be normal for this stage of pregnancy? Would you advise T4 therapy because her baby is at risk of cognitive problems? Any thoughts, or should I continue? So this is certainly normal, may be considered normal for this stage of pregnancy. So if we just reiterate some of the physiological changes, so this highlighted in blue is a non-pregnant person. And as we can see, mirroring the increased estrogen during the first trimester of pregnancy, we see an increase in the level of total T4. And this sort of continues throughout pregnancy and generally plateaus by the second to third trimester. However, if we parallel that with what happens with our free T4 levels, this is the non-pregnant individual. And what you see as we progress from the first to the third trimester, there's a steady decline in these levels. What's very important to note with measurements of free T4 during pregnancy is it's mostly done by the immunoassay techniques because these are mostly available worldwide, but these are subject to a lot of variability and lack of standardization. So free T4 levels are quite difficult to interpret during pregnancy, and hence we often adopt the non-pregnancy reference ranges in our setting. If we look at the measurements of these free T4 levels, which were done in a third trimester pregnancies, we had 30 pregnant women that were euthyroid, TPO antibody negative, and we just look at the first bar in purple here is by equilibrium dialysis, which is pretty much the gold standard, the most accurate way of measuring free T4 because it is not interfered with by heterophile antibodies or any of the binding globulins. And then we mirror that with non-pregnant reference ranges together with the third trimester pregnancy reference range. And as you can see, though T4 is a lot lower throughout during the third trimester, there's very little overlap. And this really highlights the difficulty in interpreting these free T4 assays when measured by immunoassay. As I said, most readily available to all of us. And if we mirror free T4 measurements, if we look at the left column here, we've got first trimester, second trimester, third trimester. If we look at the R coefficient, when we compare this versus the gold standard, which is mass spectrometry, you can see it's totally disorganized, mostly during the first trimester. And there's some sort of linearity that comes together towards the third trimester, but certainly not good enough, as we would see by equilibrium dialysis, which we all know together that this is the gold standard. So here you can see a nice linear line with these measurements with the R coefficient of 0.8. So this just points again to the fact that difficult to interpret these free T4 levels during pregnancy. What we all know that the variables that affect free T4 levels over and above the difficulties in the immunoassays is the differences in thyroid binding globulin together with albumin. So there are changes that occur. As we've mentioned, thyroid binding globulin generally increases by 50% in the first trimester, doubling by 20 weeks gestation. And we note a decrease in albumin levels. And this taken all together influences free T4 levels or free thyroid hormone levels during pregnancy. This just reiterates the 50% increase that we note in thyroid binding globulins, and this is a product of estrogen levels rising, and we see this is most prominent in the first trimester and then plateaus off by the second into the third trimester. And so there's a parallel rise in your total T4 levels. And this is just to recap the mirror image which occurs during the first trimester of pregnancy with TSH and HCG. So as HCG rises, because it's being produced by the placenta, it induces a reciprocal response in TSH. And this is because there's receptor spillover between the two hormones. The alpha subunit of TSH and HCG are shared, and so HCG is able to bind the TSH receptor and induce this reciprocal response, and by doing so increases the overall free T4 levels throughout pregnancy. Another important point just to mention is being able to consider gestational age-specific TSH references, and more recently, we are also talking about ethnic-specific reference ranges worldwide, because most of our reference ranges have been adopted from the American data and a lot of their cohort studies. But this just highlights the lower reference range and the upper limit of what would be considered normal for the different stages of gestation. And just to again highlight this seems to differ worldwide. The Europeans are showing somewhat different data. And in South Africa, we do not have our own gestational age specific reference ranges based on the different ethnic groups, but something that needs to be considered going forward. And so just as an overall, a TSH of 3 or more would be considered abnormal across the board throughout pregnancy. And within the first trimester, we generally adopt a less than 2.5. And this is all as per the Endocrine Society and American Thyroid Association guidelines. So just in summary, we've mentioned that free T4 by immunoassay is not robust across assays. Certainly gestational norms are needed, and that the gold standard remains mass spectrometry and equilibrium dialysis, because these are not interfered with by these changes in the binding proteins or any of the presence of heterophile antibodies. Total T4 and T3 increase by about roughly 50% above non-pregnant norms. And TSH, because of HCG, is generally lower in pregnancy. If you do detect a low free T4 level by immunoassay, the best is to check your total T4 and TSH. And if these are appropriate for gestation, this is most likely considered normal for pregnancy. So the bottom line is TSH alone is probably the best screening tool for thyroid diseases in pregnancy. Just on that note, given these thyroid functions with the isolated low free T4, does the entity of isolated hypothyroxanemia or free thyroxanemia mean anything to you? And this was first brought to our attention by these 3 studies. So Pop et al. And colleagues in 2003 showed that anybody with a low free T4 in the first trimester, so anything less than 10% of the percentile norms, was associated with delayed mental or motor function at 3 years, only if there was no increase of that free T4 later in gestation. So this really points towards iodine sufficiency in pregnancy. This was further then reiterated by Casey and colleagues in 2007, showing that an isolated low free T4 prior to 20 weeks gestation was not associated with adverse perinatal outcomes. And then furthermore, the Foster trial in 2008 showed that low free T4 in the first trimester was certainly associated with preterm labor, and in the second trimester with gestational diabetes. So really what you're seeing, and some of the more later literature is coming through, that there's no consistent patterns. It all depends on the methodologies adopted and the regions in which these studies are performed. But what's really key to consider here, whether you are deciding to treat these particular women, is your iodine status. And South Africa is one of those regions in which we still have some hotspots in which we have iodine deficient areas. In terms of treating these patients, what a lot of the studies are showing is that there does not seem to be any associated adverse immediate maternal gestational outcomes. If this low free T4 level is present in the first trimester, there are some studies that have showed lower mental scores at 2 years, a delay in language at 18 and 30 months. But more recently, we've just had the publication of the CATS trial, which was one of the larger trials, and certainly still confirming that there was no impact on cognitive outcome now at 10 years. Again, just to mention, iodine status needs to be taken into consideration, though, when deciding to treat or not to treat. If everyone's happy, we'll move on to the second case in the interest of time. Here we have a lady who's 28 years old, just found out that she's pregnant. She's 8 weeks now. She's lost well over 3 kilograms, has heart palpitations, heat intolerance. She has a very good appetite, not vomiting. She does have a family history of thyroid diseases. She has a mother with hypothyroidism. She certainly got all the features of a hypothyroid state. And on laboratory testing, just as we would suspect, she has a suppressed TSH, an elevated free T4 together with a total T4. So I'm sure this would be fairly straightforward in terms of what would we consider. Certainly most of these options are considerable, but if we had to consider or go with the most commonest diagnosis, Graves' disease would enter our diagnostic realm first. Because this is the most commonly occurring condition in pregnancy, second to gestational thyrotoxicosis, which we will touch on, but again, amongst others, they need to be considered. Gestational thyrotoxicosis, we're all familiar with this. It's a HCG hormone-mediated increase in your thyroid hormone production. We spoke about how this occurs generally in the first and early second trimester, and the condition subsides as HCG levels decrease. What's important to note, these patients don't present with a goiter and they are antibody negative. We mentioned the alpha subunit and how there's receptor spillover. And so there is a spectrum of thyroid functions which we will encounter, anything from a minimally suppressed TSH to a completely suppressed TSH, together with elevated free T4, and some women may even go on to a more severe form of hyperemesis gravidarum. This is a very important entity to identify in pregnancy because it often does not require any therapy. Serial monitoring of both the patient and the biochemistry, as majority of these women will resolve. In terms of diagnosing hypothyroidism in pregnancy, both your total and free T4 levels will certainly be above the normal ranges for pregnancy. Your TSH will be below your trimester-specific pregnant reference range. Important to consider measuring TSH receptor antibodies if available to you, and certainly to look for the clinical clues in terms of orbitopathies, goiters, and the other features of hypothyroidism. Just to mention that your suppressed TSH and elevated T4 may appear transiently in the first trimester in about 18 or up to 18% of pregnancies. Why is it important to identify hypothyroidism in pregnancy? Well, there are the well-versed retrospective studies which have confirmed the number of adverse pregnancy complications. So in your untreated group, a significant proportion of women will have a miscarriage, preterm delivery, amongst others, heart failure, small for gestational age. Obviously, if these women are attended to, the risks are a lot lower or attenuated. So certainly the result appears to depend on the severity of the disease at the time of pregnancy. Can the risks of complications be decreased? So if we treat these women, do we make a difference? And the answer certainly is yes. So we have a trial here done in 2001 showing a group of women that were actively hypothyroid during pregnancy. These women were hypothyroid initially, but were controlled either with monitoring or just antithyroid drugs. And these are your controls. And just by controlling the hypothyroid group, we see a very similar rate of low birth weight by the third trimester. Pregnancy is the entity of subclinical hypothyroidism of concern to us as clinicians? The answer is no. So this was a great study done by Casey in 2006, looking at a lot of women. He screened quite a few women in the American setting, detected subclinical hypothyroidism, compared them with women with euthyroid TFTs. Interestingly, the majority of the women who had subclinical hypothyroidism in his setting were mostly African American. And what he did note is that there was certainly a significantly decrease for gestational hypertension amongst the subclinical group. Otherwise, across the board, no difference in outcomes. So there is no validity to detecting this condition or considering treating this condition. So you make your clinical diagnosis of Graves. What would you do next? Remember, she's in the first trimester. Would you start methimazole, propylthiouracil? Would you start potassium iodide because she is so symptomatic? Or would you ablate this lady? So the jury is out, and it often depends on the setting within which you find yourself and the availability of drugs. So one may argue either methimazole or PTU, and what's the evidence? Well, up until recently, a lot of the older data suggested that there was significant transfer of methimazole, more so than propylthiouracil across the placenta, but a lot of newer data has started challenging this. The biggest concern with prescribing methimazole in the first trimester is the risk of teratogenic effects, and significant teratogenic effects at that. Conditions like aplasia cutis, choanal atresia, transesophageal fistulas, which have certainly been encountered in our setting. And more recently, the Koreans and people in Denmark have challenged the lack of teratogenic effects of PTU, and the jury is still out regarding this. This is just to depict what choanal atresia looks like and its failure of recanalization of the nasal foci. And aplasia cutis is a congenital lack of skin together with hair in an infant. The big concern regarding PTU and why we would not use it throughout pregnancy is a significant, well, quite a significant risk of hepatotoxicity together with fulminant liver damage. If we put this into perspective, though, in America, they say that 1 in 1,000 women have a chance of experiencing this. If we consider that there are 4 million births per year in the USA, 4,000 cases of Graves, that means 4 women per year with PTU-associated liver injury. So we would reserve what the guidelines advocate, reserve it for first trimester use, and thereafter swap out to methimazole if you have the availability of these drugs. So you initiate propylthiouracil, your TSH remains suppressed, your T4 is improving, you change it to methimazole by 17 weeks, and we're sitting with what we would consider subclinical hypothyroidism. What would you do now? Would you increase? Would you maintain the same dose? Increase methimazole to 30 or decrease your methimazole to 10? We would advocate maintaining the same dose. And why is that? Because the goal of treatment is subclinical hypothyroidism, and we've highlighted that this is of no concern to these women. So free T4, you use non-pregnant reference range, keep at the upper normal to 10% above. Total, you keep use your pregnancy reference ranges, which are 1.5 times the non-pregnant. And TSH, you obviously consider your trimester-specific reference ranges. So you're ongoing, you check monthly thyroid function tests, you try and aim to use the lowest dose of the drugs possible, titrating accordingly to the biochemistry. Your antithyroid drug dose can usually be lowered or discontinued by 32 to 36 weeks, and that's often dependent on antibody status. If the patient is non-compliant or high maintenance, doses of more than 40 milligrams per day, consider surgery in the second trimester, but this is often the case. This is often not the case. When would we measure thyroid receptor antibodies? Generally, we do at the end of the first trimester. Some guidelines advocate towards the end of the second trimester. If negative, you don't need to repeat. If it's positive, you know that you need to repeat. And why we would do this is because of the risk of these antibodies crossing the placenta, the implications for the fetus, and hence we like to do fetal ultrasounds at 28 to 32 weeks, assessing for fetal goiter. Remember, LT4 replaced hypothyroid women with Graves also need to have these antibody measurements done because these often don't dissipate upon treatment. This is just to highlight a stone of one of our fetuses that had a goiter, and the consideration is always, is our lady hyperthyroid or hypothyroid? And how do we tease this out? So just a nice sort of way of looking at it. If you've got a mom who has active Graves' disease, she's overtreated, she's got with antithyroid drugs, inappropriately normal or low TFTs, certainly think of hypothyroidism. If your mom has active Graves, but she's not controlled, think hyper. And a mother with hypothyroid mom with history of Graves, again, think hypothyroidism. If you're still not sure, you may consider percutaneous umbilical vein sampling. I see we are already on 25 minutes, so I'm sure you would like to stop there just for some questions, or would you like me to continue with the next case?
Please continue, ma'am. I think we have.
Okay. Okay, so here we have a 32-year-old female, second pregnancy, 6-year history of primary hypothyroidism. She's currently taking 100 mics of levothyroxine and her serum TSH is 3.9. She wants to try and conceive again. So what would you advise her? Should she continue on the current dose and check her TSH level again at the end of pregnancy? Continue the current dose, but make sure TSH levels are checked at the end of first trimester, increase her dose by about 20%, or continue her current LT4 dose, but check serum TSH as soon as pregnancy is confirmed. We certainly would advocate an increase in thyroid hormone replacement. And the reason being is that we aim to have a TSH of less than 2.5 preconception in order to create an optimal environment for the fetus, because you know the fetus relies on maternal LT4 during the first trimester. And then again, you try and achieve your targets in the first and up to the second and third trimester in terms of TSH. So we increase our dose. 6 weeks later, the TSH is 1.8 and she falls pregnant. Now, what would you advise her? Your last TSH prior to conception was fine prior to conception. You don't need any further increases. All your hypothyroid patients require more LT4 during pregnancy. So take 3 extra pills per week. Or some hypothyroid women do require more LT4 when pregnant, but if your TSH now, but that you are pregnant is less than 2.5, your dose will not need to be changed for the rest of gestation. Check her TSH now and continue to monitor TSH during pregnancy with LT4 dose adjustment to maintain her TSH of less than 2.5 to 3. Okay, sorry. So we would check her TSH, continue to monitor, and aim for those trimester-specific reference ranges in terms of TSH. In terms of our decisions to do all this is because it's important to optimize your preconception LT4. We have mentioned the reliance of the fetus upon the maternal T4 in the first trimester until such time as their axis is functional. And this was a nice study just looking at what level of TSH should we consider preconception in order to alleviate massive increases during the pregnancy. And it seems like the magic number is less than 1.2. Only 17% of individuals will require LT4 dosage increases at their first antenatal visit. Do all women with hypothyroidism prior to pregnancy on LT4 require a dosage increase? And the answer is yes. The degree of increase differs depending on the underlying condition. So women who have any autoimmune conditions would require at least a 1/3 to 2/3 increase, whereas 100% of women who do not have a thyroid would require an increase, and that makes sense. So now she's 6 weeks, her TSH is 7.1 on this 20% increase. Her dose, quite rightly so, was increased again to 150 mics per day, and 4 weeks later, we're exactly where we'd like to be. So generally, what is the timing of, so if you've missed the preconception period and and you haven't increased the dose, generally we notice the biggest rise in requirements between 6 to 8 weeks in pregnancy. And this increase occurs early if disease-specific gestational TSH targets are being targeted. For instance, in your general hypothyroid patient, you're aiming for less than 2.5, but certainly in women who've had a history of thyroid cancer, you're aiming for a lot lower TSH level. So you're going to expect a lot earlier rise in the requirements and a greater rise in the requirements for these women. So on average, we're looking at about a 45 to 50% increase requirement for women who don't have a thyroid. Hashimoto's about 25 to 40%, and this does vary based on individuals. And subclinical hypothyroidism, we don't see any, or there's no increased requirements. Now there is serum TSH is 1.4 on 150. She's now 10 weeks. Is she going to require any further increases as her pregnancy proceeds? And the answer is yes. Most patients reach a definitive dose adjustment by about 20 weeks gestational age. 25% of those with the initial normal serum TSH in the first trimester, and 35% of those with initial normal TSH in second trimester will later require dosage increases. So it's not a hard and fast rule.
Dr. Veronique,
Yes.
sorry to interrupt. It's time to wrap up the session because there are a couple of questions.
No problem. And apologies, it's long. There's just so much to take you through on thyroid disorders in pregnancy and the different avenues, but really happy to take questions and to stop there.
Okay. There are a couple of questions. The first question is, what is the drug of choice, dosing, and duration of therapy in hypothyroidism in pregnancy?
So the drug of choice remains LT4, or depending on where you are, it's Euthyrox in South Africa, but we don't replace with LT3. And the doses, it's a difficult question, really dependent on what your patient was on pre-gestation and what the condition was predating the pregnancy. So, but on average, we generally increase between, just to make it easy for the patient, you can tell them if they've just tested themselves pregnant or they're positive, they can increase their pills by about 2 to 3 pills per week, which generally gives you about a 20 to 40% increase, which is what we're looking at, until such time as they see the clinician and have a formal thyroid function test. But as we've said, you must expect that there's going to be an increased requirements generally up until about 20 weeks gestation, but some women do go beyond that.
Yeah, I agree, Dr. Veronique. There's another question, which is the anti-thyroid drug of choice in a newly diagnosed Graves' disease who's planning for pregnancy?
So she has not fallen pregnant, I take it. So we would give methimazole. And if we know she's planning on falling pregnant, look, in South Africa, we don't have propylthiouracil. So we've got quite a lot of experience with methimazole in pregnancy. The guidelines would advocate, though, if there is a good chance she's going to fall pregnant, propylthiouracil should be the agent of choice as we currently speak. But there are more and more studies coming through now from Korea showing that there seems to be quite significant teratogenicity also associated with PTU. So we'll see what gets prescribed in the newer guidelines in terms of these two drugs.
Thank you, Dr. Veronique.
Sorry, I lost you there.
Hari, you're muted.
Am I on mute?
No. Sorry, ma'am. Thank you for your excellent presentation covering the various aspects of thyroid dysfunction. The case-based scenarios were really thought-provoking, and I think it's time to conclude our session.
Thank you so much for the opportunity, and I do hope that they could share the rest of the slides with you. The cases are very important to go through. Thank you.